I'm going to present a case of simple varus deformity. She is a 65 years old female, stage 4 bilateral OA with flexion deformity. History of hypertension is present. There is no comorbidities. On examination, 40 degrees of varus and 10 degrees of flexion deformity. Range of movements is 10 to 90 degrees painful. Varus deformity is fixed. It's not correctable with the stress. And preoperative workup is fine. She is fit for surgery. So she is a preoperative gait of the patient.
All right, so Suri, do you see any challenges here?
I didn't get you.
How would you tackle this?
Oh, yeah. Can I have the X-rays? Can you? Oh, yeah. I think a lot of this is the medial condylar osteophytic overgrowth with subluxation. The more often when there is subluxation, you normally find moment you release the osteophyte, take out the osteophytes, you are able to correct it much easily. So my approach here in this case would be basically, I think you find some anterolateral, define the hypertrophied posteromedial condyle, standard anterior parapatellar approach, remove all the osteophytes. My only concern here is whether there is any calcification in the patellar tendon area. That is the only point of concern. If that be the case, then rather than everting, I would take a probably small osteotomy and evert it, or a snip above. Excise all the osteophytes, the tibial, standard tibial cuts. The release on the medial side of the tibia may need to be probably a little more distal. It will be a composite sleeve that comes down. And I think we should get it.
So what kind of knee are you putting in?
In this case, most likely it is going to be a PS with a short stem on the tibial side.
Okay, does anybody want to do anything differently?
No, I think the same, but the osteophyte on the tibia at the back is really large, and I think that that's going to make it very difficult to bring this forward. I think the trick is to use a curved osteotomy and just disengage that at the back end of the tibia, and then you would be able to bring it in front.
Anybody worried about neurovascular structures?
Yeah.
Anybody
I'm
want to
saying
get
this one, you have vascular, they know you're doing this case, just in case, right? So you want them on call in case you get in the trouble back there. A lot of this hyperextension, so you got to be careful. Once you remove that massive osteophyte, you're going to get into more trouble. So you're going to have potentially a massive amount of recurvatum. So having revision implants with distal augments available would be helpful.
I think what I was mentioning earlier, there is tremendous amount of flattening of the condyle here, which is what is causing that hyperextension. And I think the cut you're going to need on the femur is going to be hardly any.
Yeah. And what about the popliteus? Dr. Rajgopal, do you have any concerns about the popliteus tendon?
I don't really worry about the popliteus.
Okay.
Yep.
So, in the past, I used to snip the popliteus tendon in very severe varus knees as this, because when there is so much subluxation.
Yes.
That is the last structure that you may have to deal with.
That's why I asked the question.
Yes, and you're right that even now this may be needed in this patient, but I would keep it till the end. At trialing stage, if the knee is still jumping into a little bit of varus, and then I would look at it and then snip it.
I agree. Anybody want to add anything?
The tibial the downsizing also will be partly helpful, because looking at the femur, I think probably the tibial flare on the medial side can also come down, helps you to accommodate the varus.
A little reduction osteotomy?
Yeah. Yes.
Good. All right, so tell us what you did.
These are the immediate post-op. I did a regular straight knee replacement with all poly. The bone defect in tibia managed with the screws and cement.
The only thing I'd say, I think it looks like a beautiful technical job. To be honest, even though I think all polypatellas are tibias are pretty good, this is one situation where I'd be a little reluctant to use it with a graft on the medial side. I think a metal-backed implant might be a little safer in the long term.
I agree. Anybody concerned about the joint line?
Patella looks pretty good.
Okay. So how do we do? Good.
These 5 years post-op gait.
So
Yeah, the
and why didn't you do the patella?
Sorry. Oh, I have not done patella. Yeah.
Is that your
No,
routine?
it's a tracking. Those days I was not resurfacing patella. Now I used to resurface every patella.
Okay.
You know, what did you use for DVT prophylaxis, or do you give the patient anti-inflammatories post-op? Because the hypertrophic OA like that, you worry about arthrofibrosis and maybe even HO, post-operatively.
No, I didn't find any arthrosis.
Do you use aspirin
Sorry?
for DVT prophylaxis?
No. DVT prophylaxis. I used to give Fragmin 5 days and 3 months of Ecosprin 75 mg.
I see the patient's not really moving or need too much. What's her final range of motion on that side? Did she get stiff post-op or?
No. She without support, she's walking like that. With the stick, she's walking normally.
But her range of motion?
Range of motion is good, 0 to 90 degrees.
Okay. She's really.
These are the 5 years post-op X-rays.
All right.
Looks great though.
Any other comments? All right, great job. Thank you.